Angela Berg, nurse practitioner with Care for the Kids here. Welcome to another fabulous episode of Healthy Happy Hour. We are changing our format a little bit for this series, and we're going to do a conversation again with Dr. Joshi, our new rheumatologist here at Care for the Kids. It was so popular when we did this before, and we heard you ask for more discussion with Dr. Joshi and picking his brain a little more about juvenile arthritis, as we really focus on that as one of our most common concerns for rheumatology referrals that happens. So welcome, Dr. Joshi, back to Healthy Happy Hour. Thanks for being here.
It's a pleasure to be here again, Angela. Thank you for having me.
Absolutely. So as always, our conversation is always great, even as we work together every day. So let's start off just a little bit talking about the different types of juvenile arthritis, because I think people think arthritis is arthritis, same as adults as in children, and they think of joint pain. What are some of the red flags really that should be making people consider arthritis versus something that is joint pain, the most common joint pain being just growing kids? Let's talk about that.
Right, so let's tackle the second question first about the red flags. A very common confusion is distinguishing arthralgia from arthritis. And arthralgia is joint pain, which has a much broader differential diagnosis as opposed to arthritis, which is joint swelling. So it's the joint swelling that really teases the two apart. And if I were to say there is one symptom to really closely watch out for, it would be swelling of a joint, which means that the joint looks and feels puffy or boggy, like there is extra fluid inside it. If that's the symptom, and joint pain may accompany joint swelling, but it is the swelling that really teases the two apart. We can also say that sometimes the swelling, the joint pain could be worse first thing in the morning in inflammatory arthritis, and these symptoms typically improve as the day goes by, as opposed to other biomechanical overuse and other related disorders in which the symptoms would typically be worse at the end of the day. The other thing that we should talk about if you're talking about red flags for arthritis is stiffness. And stiffness is something very specific. It is also called as gelling, which means that when I am sedentary, when I'm sitting down, it just seems like that the joint is becoming stiff or gelled up, is not moving as nicely and freely as it should. And when I walk around or move that joint, that feeling gets better. And joint stiffness, especially worst first thing in the morning and improves as the day goes by, is another one of those red flags. And the final one that I want to bring up is warmth, which is, and we typically want to use the back of our hand to just put over a joint and compare it to the other side, which might not be as involved. And if we see that there is a rise in local temperature, or also called as warmth, that would be a fourth sign. So these are the four big red flags to pick up juvenile idiopathic arthritis. Most important being joint swelling. Number 2, joint pain worst thing in the morning. Number 3, joint stiffness worst first thing in the morning. And number 4, warmth over a joint.
Thank you, and that brings me to some of the early lessons I learned as I started practicing rheumatology, is that there can be joint swelling with an acute overuse injury that is caused to tissue. Let's talk a little bit about that versus an arthritis kind of swelling. It's not going to come and go in just a 24 to 48 hour period versus that an injury. Talk a little bit about that. How long do you expect swelling to last for arthritis versus an injury? How do we tell the difference?
Right, you bring up a really, really good point. Let's take a step back and ask the question, where is the swelling coming from? So like we have a skin on the outside, there is also a skin that lines the joints from inside. that is called as synovium. And when that synovium gets irritated or inflamed, it starts secreting extra fluid into the joint cavity. And that extra fluid, we perceive that extra fluid as joint swelling when we look from the outside. So I won't be wrong when I say that juvenile idiopathic arthritis is nothing but synovitis, which means inflammation of the synovium or inflammation of the inner lining of the joint. Now, there are many biomechanical disorders, some of which you brought up, like overuse injuries. Someone is playing a lot of basketball and using both the knee joints, especially with jumping activity, or many people have what we call as a lax patella or a lax kneecap, which means that kneecap is grinding too much side to side because it is very flexible. All these are biomechanical disorders which can also irritate that inner lining of the joint and cause a little bit extra fluid to accumulate within the joint cavity. However, there are two ways that we can distinguish this type of swelling from true JIA. Number one, the swelling won't last for more than 24 to 72 hours. And it would dramatically improve with rest. If you rest the joint, ice the joint, heat the joint, some of these conservative measures, then you would see that there is a dramatic back to baseline. The swelling disappears or at least gets remarkably better. As opposed to JIA, in which most of these measures would only be met with a little bit of improvement, but the swelling would stay there persistently. So it's the persistent swelling of a joint that lasts for days and weeks and months on end, which is a red flag for JIA. Number two is the amount of swelling. Most of the biomechanical disorders would just cause a little bit of swelling that you can see appear after you have used the joint too much, but it would not nearly be as bad as what we see in JIA, in which the whole joint swells up. It almost looks like a balloon, and it would be a lot of fluid. It won't be something subtle that you would really have to look for. It will be obvious across the room. You can just look at the joint and say, oh, as compared to the other side, this one looks really swollen. So I would say these are the two ways in which we can distinguish two of the most common causes of joint swelling in children: true JIA, juvenile idiopathic arthritis, which is an autoimmune disease, and biomechanical disorders, which are happening because of overuse or some biomechanical abnormalities in the joint.
Such a good point, such a good point. And I think so many people think that swelling that comes and goes is consistent with arthritis in kids. I think that may be something that maybe my aunts and uncles who suffer with rheumatoid arthritis, adult onset rheumatoid arthritis, they probably have swelling that comes and goes a lot more often, and I think that is what most of us get experience with. The other point that really struck me as we've been talking about this is pain. I was blown away when I first started working with kids with rheumatologic disorders to see how little pain juvenile arthritis kids complain about. They don't even notice the stiffness in the morning. The parent seems to be the one that notices the stiffness in the morning. So you really have to press them for that information. How hard is it to bend your bendy parts in the morning? And
Right.
Parents are the ones who have to really focus on that, because kids, if it's not an injury and it's really arthritis, they complain very little.
100%, and I think that's a great point, and I would just like to elaborate that a little further. So there is some data to show that a quarter of children who have JIA do not have any joint pain. So that just tells us that the early signs of JIA can be very subtle, and younger children might not be able to articulate the joint pain very well. And as I just told, 25% don't have any joint pain. So then it becomes the responsibility of parents to watch very closely for signs. And I would just bring up two common signs that I think the parents can watch out for. One is limping first thing in the morning. if the child has an abnormal gait or a limp when they get up from the bed first thing in the morning, and that improves as the day goes by, that would be something to watch out for and could be a sign of early JIA. The other one is gelling, which means when we are sitting on the couch and watching a movie, that's the time when the joint symptoms come up.
Or playing video games.
Or playing video games.
So many of those kids are sitting for a couple hours at a time doing video games.
Yeah. Or another very common one would be going for a long car ride.
Yes.
When I'm sitting down in the car for a long time, that's when my knee starts to act up. It starts to hurt, it starts to gel up, become stiff. So these two, morning predominant limp and gelling when I sit down, are two of the key symptoms that parents can watch out for.
I think probably one of my most profound experiences in early diagnosis of JIA was seeing kids come in with that very abnormal walk, and the precipitating issue that made them actually ask about the issue was they can't a baseball player, for example, can't get to first base fast enough before he gets out. He doesn't run as fast as he used to. And when I actually see him walking in on his toe without being able to straighten a leg completely out, and that knee is profoundly affected, it seems to be sneaky to them, that it comes on gradual and they don't really notice, but it's function that ends up being the factor that makes them go, oh gosh, that knee does look funny. You are walking funny. I've had moms say to me, I was going up the stairs behind her and didn't realize how funny she's doing stairs, and that she didn't used to do it that way. So talk a little bit about some of that experience. I think that stiffness with sitting, with age, we expect that we gel up a little bit with sitting, and we got to get our bendy parts loosened up, and we know that a body in motion stays in motion.
Right.
And we've talked about that before, but talk about some of your experiences with
that. Well, again, I think you bring up a really good point. Another very common symptom of early JIA, as you said, the early symptoms could be sneaky, is just a reduced amount of physical activity, or the ability to exert oneself. We call that exercise tolerance, which means that before I used to be able to do this much, but now I can only do this much. And there is a lot of data to show that children who have been diagnosed with JIA and are in remission on medication also are not moving nearly as much as their healthy peers, which means that JIA in a way deconditions the joint and makes us, whether it's conscious or unconscious, but not move as much and just try to guard that joint, and we see that as reduced exercise tolerance or exercise ability. So that's when the role of physical therapy and spreading the word about how important it is, as you rightly mentioned, a body in motion stays in motion, how important it is to keep the physical activity ongoing. And here I think it's a good segue into bursting one of the most common myths about JIA, which is if I use my joint more, it's going to damage my joint more if I have arthritis. That is not true.
Yeah.
In fact, the exact opposite is true, which means that if you have JIA in a joint, you need to make sure that you are either enrolled in a formal physical therapy education, or you are doing what's called as HEP or home exercise plan, but you need to stretch and strengthen and maintain the range of motion and the balance and the flexibility in that joint, more so than if you did not have arthritis in that joint.
Yes.
So we never want to give the message that if I have, I'm a child and I have arthritis in my knee, I should guard it and not move it. You should not absolutely do that. You should try to return to baseline, do all types of physical activities as a normal healthy child would.
Yes, I love that. I want to dig into that a little bit deeper. So let's do a whole segment on that about the types of physical therapy and the types of things that we recommend. So let's do that for a whole segment on its own. And for now, we're going to take a quick pause. Stay right where you are. Don't leave us. We will be back with more information about juvenile idiopathic arthritis and other rheumatologic disorders, how we work as a team, what's different here at Cure for the Kids. So don't go away. Hi, welcome back to Healthy Happy Hour. I'm Angela Berg with Cure for the Kids Foundation, and I am here with Dr. Joshi as we continue our conversations about juvenile idiopathic arthritis, and we may touch on a few other rheumatologic diseases as well. But I want to dig deep into that whole body in motion, self-restricting activity, how the different types of physical therapy help. So let's talk a little bit first about, we alluded a little bit before about that body in motion, staying in motion, and the importance of keeping movement. Particularly, I've seen kids in my rheumatologic experience here develop contractures that we have to work really hard at, because there is that myth that people think you should not use the joint. If the joint has arthritis, don't use it. And I've seen even shoulders, which shoulder arthritis in kids is very uncommon, but I've seen a frozen shoulder before, and a kiddo have to have orthopedic surgery to help with a frozen shoulder. So talk a little bit, Dr. Joshi, about your experience with the importance of moving and some of the most helpful things that physical therapy or types of physical therapy, such as swimming, maybe, for example.
Right. Yes, so JIA is an autoimmune disease in which the immune system is overacting and attacking the joint and causing inflammation in it. But then it can lead to a lot of biomechanical sequelae as a result of that inflammation, which are very well served in the realms of physical therapy. And the three most common types of biomechanical, so as to say, complications of GIA that we see, one is something called as a flexion contracture, which means that because I straighten my joint all the way, it causes pain. I don't do that. I always keep it a little bent. And the most common clinical example would be a knee, and the child is not able to straighten the knee all the way out, always keeps it a little bent, because straightening the knee all the way out would cause pain. And over the course of time, because we are not straightening the knee all the way out, the tissues, which are called as the fibrous tissues around the joint, just stay in that bended or contracted position, and then we are not physically able to straighten the knee all the way out, and that is called as a contracture. And of course, using medications to treat arthritis would do its part, but what is very important is to bring back that lost range of motion, and that's when physical therapy becomes very, very important. I might have alluded to this point before, but children who have GIA in remission are also not moving nearly as much as their healthy peers, which can also cause what's called as disuse atrophy, which means that the muscles right before the joint which is involved, I'm not using them as much. And the technical term would be something called as disuse atrophy, which means that if I don't use that muscle, I'm going to lose the bulk of that muscle. And that is another very common clinical biomechanical complication of GIA, and which is very well served in physical therapy. So contractures, the treatment in the realm of physical therapy for contractures is something called as range of motion exercises, which is, an easy way to explain would be stretching. Stretch that joint to its fully possible potential for the range of motion. And the disuse atrophy, which means not using that muscle nearly as much, in the PT realm, the treatment would be strengthening. So these two are the key PT modalities or types of exercises which physical therapists would use to bring back the joint to its healthy baseline from being affected in JIA. One is range of motion or stretching type of exercises, and number two is strengthening type of exercises. Now, the environment matters a lot too. Whether we do these two type of exercises on the land or in water. So physical therapy are of two types, land therapy and water or aquatic therapy. And in my experience, if the lower part of the body is being involved, like lower back joints, hips, knees, ankles, and feet, it might be better to do these physical therapy exercises in an aquatic environment. And that has a lot more benefits over the land environment. And number one, you are not weight bearing, which means that you are buoyant, you are utilizing the buoyancy of the water to de-stress the lower part of the body. Because if you look at it, anytime you are standing or even sitting, you still are bearing some weight on the lower part of the body, as opposed to being in a pool in which for the first time your joints don't have to bear your own body weight. And that in itself can be therapeutic. But also the maneuverability of a joint in an aquatic environment is much more as opposed to a land environment. And for some reason our pediatric patients also love the idea of spending time in the pool because it can also be very relaxing. The touch of water can also be very relaxing. So I always tend to favor aquatic therapy over land therapy whenever it's available and we can make it happen. And not to say that land therapy also can be very helpful. And the other type of therapy is something called as occupational therapy. And occupational therapy is a little different from physical therapy in the sense that the focus of occupational therapy is usually towards fine motor skills. And in the context of JIA, occupational therapy or OT becomes very important when the hand is involved. When the small joints of the fingers, those are contracted, it would be much better served under the expert guidance of a hand occupational therapist to bring back, and the concepts remain the same. It's the range of motion, the stretching, the strengthening, but it's just a more specialized field. And that's when we really make a case for PTs and OTs being therapeutic providers. They can bring back the lost range of motion and the lost muscle mass, but also prevention. Healthy children who don't have any of these complications just yet, like contractures or disuse atrophy, even they would benefit. And more PTs that I personally know are projecting themselves as preventionists, which means if you do physical therapy, you're going to prevent these complications from happening in the first place.
Yeah, a couple of complications that I've seen in my time doing pediatric rheumatology with the CHLA team and with you are, if we're very delayed in getting diagnosis, there's two other complications that happen. We get synovial hypertrophy or overgrowth, large synovium, so we'll get a joint that won't return. I know we keep referring to knees frequently, and so in an upcoming segment I want to talk about the importance of all the other joints that we frequently see. Oftentimes in our oligo kiddos with fewer joints, it's the knee. And so I think people most commonly think of the knee, but even if we can't get them physical therapy, I always like to still talk about the importance of get in a pool. Any pool you have access to, get in water up to your chest and just walk back and forth, back and forth. That buoyancy of being not on weight bearing and that ability to condition those joints for movement through the water is so important. And in Vegas, we almost all have access to a pool of some type, even if it is a community center pool and it's $3 to get in. That's oftentimes less than your copayment for a physical therapy session, and you can still do that physical therapy yourself. But I've seen bony overgrowth where we absolutely cannot recover full range of motion. Particularly, I've seen that in wrists mostly on kiddos here. So I think it's important for parents to recognize early too, if maybe there's not a huge amount of swelling, but if you start seeing those kiddos not using, they're right-handed their whole life, and you see them start using their left hand, or not be able to open lids of their juice bottle themselves or their milk carton themselves, those kind of things. I think it's important because that is an area that with that increased blood flow of that inflammation, that bone overgrows and then we can't get that mobility back. I think that's an important part for us to make sure people understand too. So use it or lose it, keep it moving, and if it's not moving, recognize it early, I think are probably, would you agree, some of our base messages that you have to keep in mind.
I would agree 100% with that, and I just would also like to add that because we are talking about physical and occupational therapy in this segment, I think that the non-pharmacologic therapeutic modalities sometimes are not as frequently talked about, and we should definitely spread the word about how useful and helpful they can be in conjunction to the pharmacologic treatment.
Yes.
For example, the use of heating pads, the use of a Epsom salt bath, or as you correctly pointed out, the use of a pool if you have access to it at home or nearby, the use of massage, therapeutic massage. All these are modalities which are very helpful and should be practiced and performed in conjunction with the pharmacologic treatment.
And use integrative therapy things such as natural arnica cream for that massaging and stretching. And a lot of good massage therapists offer stretching as part of their therapy now. So if that is available to people, we certainly do encourage you to do that as well. That is all the time we have for this segment, but I don't want you to go anywhere very far. We'll be back. See you soon.